This patient with refractive error of -14 dioptry sphere and -1 diopter of cylinder at 10 degrees planned for phakic ICL as he was not suitable for corneal ablative procedure. As per the standard procedure, the ICL was loaded into the injector cartridge with the optic facing upward using the specialized loading bud provided by the manufacturer. The lens was gently pulled into the nozzle using ICL holding forceps. To ensure proper toric alignment, reference markings were first made on the slit lamp at 0 and 180 degrees. These markings were then confirmed and reapplied on the operating table to achieve desired alignment. The ICL was injected through a 3.2 millimeter corneal incision. However, upon entry, the lens unexpectedly flipped and rotated 180 degrees, unfolding with the optic surface facing posteriorly toward the patient's natural crystalline lens, almost making contact. Recognizing the risk of lens damage or potential complications, we immediately decided to explant the ICL. Using McPherson forceps through the same incision, the lens was carefully removed, taking utmost care not to touch the optic portion. The ICL was then reloaded into the injector system, this time with additional precautions to ensure the correct orientation of the lens. The injection was performed slowly and steadily, with deliberate clockwise and counterclockwise hand movements to monitor the correct orientation of lens. Once the lens was observed to be unfolding correctly, the plunger was fully advanced. The ICL was then rotated to achieve the intended toric alignment. Following proper positioning, the viscoelastic was thoroughly removed and the corneal wounds were securely hydrated. On the first post-operative day, the patient achieved an uncorrected visual acuity of 6.6, and the patient was extremely satisfied with the result. So this case highlights that early recognition and the immediate correction of an inverse ICL can lead to optimal outcomes without the need for a second surgical intervention. Thank you.